Regina Nanoga from Nation Media Group, NTV to be particular. I'm deeply honored to stand with you as your master of ceremonies for the Uganda National Conference on Health, Human Rights and Development 2025. And this is the second edition here at the Steel Hotel in Kampala. Now for the next 3 days, from the 3rd of September, which is today, all the way to the 5th of September 2025, we are converging under the theme, Right to Health, Bridging Gaps Across Other Sectors, and also Achieving Equitable Health. And that is for you in this room and for the people that are not in this room. In other words, for all of us. And not just Ugandans, but the entire world. Now, before we embark on this journey, allow me to have a special recognition of those that have blessed us with their presence today. We do have the Office of the Prime Minister, the Right Honourable Prime Minister of the Republic of Uganda, who will be joining us later on, our esteemed guest of honour. We also do have the Director General Health Services from the Ministry of Health, who is already in our midst. We also do have representatives from World Health Organization, and this is to Uganda. Allow me to also recognize honourable members of parliament. It's a busy season. People are preparing for nominations, which have kicked off today with the Electoral Commission, but members of parliament that have managed to make it here, we want to say thank you so much. Allow me to also recognize the Executive Director, National Planning Authority, that will be in our midst. We do have the Director Budget, Ministry of Finance, Planning and Economic Development that will also be addressing us. We also want to recognize different representatives from the government ministries. We do have departments and agencies, including Ministry of Education and Sports, Ministry of Justice, Ministry of Water and Environment, Ministry of Finance, Planning and Economic Development. We also do have representatives from the Ministry of Gender, Labour and Social Development. We do have the Ministry of Local Government, and I've seen some local government leaders from Namutumba. Hello. The Mayor of Namutumba District. Yes. We also do have the Ministry of Works represented, Ministry of Agriculture, Animal Industry and Fisheries, the Ministry of Trade and Industry and Cooperatives are also representatives in this room, the Judiciary, Local Government, and of course Ministry of Health, the Parliament, Equal Opportunities Commission, Uganda AIDS Commission, and universities. We also do have representatives from the Ministry of Health, and this is from our neighboring country, Kenya. We also do want to recognize foreign missions representatives in the room. We also do have UN agencies that are well represented in the room this morning. Trustees and Board of Directors from the Center of Health, Human Rights and Development, also known as CEHAD, which are our co-host for this conference. You're most welcome. Civil society and community-based organizations that are also part of this journey. Private sector actors, members of the media, you're all very welcome. We also want to recognize religious leaders and cultural leaders that received an invitation from the Ministry of Health and CEHAD and said, yes, we need to be in that room. Thank you so much for being here. We also want to recognize the young people, the people we are all serving in our different entities and capacities, and of course to regional partners that are here with us from Kenya, from Tanzania, and also from South Africa. You are all most welcome. Now you may wonder, why so many people, why so many sectors in one room? Because at the end of the day, we are all responsible for the health of not just our own selves, or personal selves, but also for the health of our communities that we serve and the general public, and that is the Uganda. So you are the beating heart of this conference without a doubt, and your presence is here to reflect a shared commitment to making the right to health not just a promise, but a lived reality. And therefore, as you are here in this room, we trust that your contributions are going to be immense in helping shape the direction and ensuring that there's equitable health for all. Now, did you know that nearly 38% of Ugandans are still facing barriers to essential health services? Many of them are stemming from the fact that there's lack of doctors in hospitals, and if the doctors are there in the hospitals and there's no medicine in the hospitals, if the medicines are there, then the professionals that are attending to the different categories of the diseases and ailments that we have in the country are not there in these facilities. And that's just one side of it. Did you know that this is also having a complex interplay with education? How our children and students take in education? What are the environments? How healthy are those environments? And this does not stop there. Water and sanitation also makes a big contribution to the well-being of humanity. We do have food security, which has been a very big conversation for us on a national level here in Uganda. Governance, infrastructure are all part of making sure that it is equitable health for all. Now, that is why this conference is mattering today and for the next 3 days, because health is not built in isolation. It is forged across sectors, it is forged through collaboration and with equity at its core. So as a journalist at NTV, we've had the privilege of telling many of these stories, and many of you have watched them. Your hearts are being touched. And there's pain, but at the same time, I can tell you there's progress. There's progressive steps that have been taken. So standing here today, I feel that this is a story of possibility that we can all tell collectively, one where health, human rights, and development are no longer silos, but also they are strands of one strong rope pulling our nation forward and push the other nations that are presented in this room. So with that spirit, allow me to warmly welcome you on behalf of the Ministry of Health and SEHAT to this conference that is promising dialogue, is promising actionable steps, and is promising a renewed sense of duty. And together, let us bridge the gaps that do exist for the different sectors that we are representing so that we can have equitable health for all Ugandans. Let us champion equitable health at the end of the day. And now to officially set the pace, allow me to invite from the Ministry of Health, that is the official host of this conference, Mr. Emmanuel Ainebiona, Senior Public Relations Officer.
As my co-MC, and I wish to also take this opportunity to welcome you to this second edition of the Uganda National Conference on Health and Human Rights and Development. My name is Emmanuel Ainebiona, Senior Public Relations Officer at the Ministry of Health, and I'm privileged to be at this second edition. Could we at least whisper to your neighbor that health is the greatest possession? Thank you. That is a quote from a Chinese philosopher called Lao Tzu. And indeed, health is the greatest possession. I will be working alongside Bukenya Wycliffe for sign language. We are all inclusive as the Ministry of Health and our partners SEHAT to bring you this second edition of the Uganda National Conference on Health, Human Rights and Development. And also another sign language interpreter is Nachigos Olivia Bulenga. They will be supporting us such that we are all inclusive, because equity is also a human right. I am here to invite our first speaker who will be giving us our remarks, and this one is our Director General of Services, Dr. Charles Olalo. And Dr. Charles Olalo has been in this position for some time, and he has served as a surgeon. He has experience as a healthcare professional, having been the accounting officer of Arua Regional Referral Hospital, Fort Portal Regional Referral Hospital. He was overseeing the continuity of care during the COVID-19 pandemic. He's the champion of sexual reproductive health rights and also self-care, and is known to most of us. Allow me invite our Director General of Services, Dr. Charles Olalo. You're welcome.
Good morning. Morning. At least that's better. Otherwise, now I'm assured of your wellness and your health. The honorable members of Parliament, Kenya and South Africa. We want to welcome them to this conference and look forward to exchanging learning with you. So I want that we take this opportunity, and this conference definitely is a follow-up of our inaugural Uganda Conference on Health and Development, which was held in 2023, in which we strongly reminded that about health as a fundamental human right and is a cornerstone for realization of sustainable development goals by 2030, which is not far from now, and the Uganda Vision 2040. So delegates recognize the need to tackle health inequities and inequalities through national political commitments, policies and international cooperation with an emphasis on social determinants of health. Commitments were made that time on strengthening the collaboration across all sectors, and as you clearly heard, almost all sectors in this country are represented here. And that's also why we took the initiative that the guest of honor of this program definitely none other than the Right Honorable Prime Minister, because he pretends over this role of supervising all the other sectors. So this commitment, as I have highlighted, that we're inspired with this, is what inspired our theme for 2025, which is the right to health, bridging gaps across other sectors, and achieving equitable health for all. With only 5 years, less than 5 years to 2030, in which for us to fully realize the promise of leaving no one behind, and 15 years to realize the Uganda Vision 2040, we must collectively identify the game changer for accelerating progress towards universal health coverage, and that recognition that universal health coverage is a key strategy for realizing equitable and sustainable healthcare systems, ultimately the right to health. It's important for us to remind us that health goes beyond access to healthcare. It encompasses the broader social determinants that shape the people's well-being. Much more attention has been given to addressing the persistent health challenges within the healthcare system, which has registered achievements. And all of you know that in 2022, during the Uganda Demographic Health Survey, we had a marked reduction in maternal mortality to 189 per 100,000, and also the infant mortality. So as we stand here, we definitely need to thank ourselves that a lot has been achieved. But do we want to contend with so far what we have achieved? I think no, I think we should be able to do much more, much better. And that's why we are calling that if each of the other MDS, other sectors, made their contributions, then we will be able to realize health and well-being for all. So, definitely key challenges and bottlenecks remain mainly on areas of sexual and reproductive health. Young people, you all know the risks young people go. The double burden on communicable and non-communicable diseases, the increasing cases of mental health conditions, traffic incidents, and emerging threats linked to climate change. So the theme of Uganda Conference on Health, Human Rights and Development 2025 is timely reminder that health does not exist in isolation, and is not actually domiciled in Ministry of Health or the health sector. It goes beyond that. And I wonder that by the time we live here, we are clearly advocates for that. It is shaped by social, economic, political, and environmental conditions in which we live. This includes but not limited to access to clean water, sanitation and hygiene, food, nutrition, education information, decent housing, safe working conditions, social inclusion, and a clean and healthy environment. It's documented that these conditions are responsible for 80% of the health outcome, yet they are outside the health sector. So as the health sector, we probably contain and take care of only 20%. 80% of them are completely outside. The other aspect which I want to emphasize is the key role which individuals, families, and communities play. That will have a very big role to be able to see that how we mitigate the risks. And the risks definitely are quite many. Aspect of tobacco, alcohol, the food we eat, the lack of physical activity, and those are all under your control and ambit. Why are you not doing them? Is the question which I want to ask. If you know that exercise, physical activity, not smoking, taking alcohol in moderation, at least I've not reached the point where I'm saying stop taking alcohol, I've said taking it in moderation. You should be able to know that risk. And all the other risk behaviors. So, the conference paper has come at the beginning of the Uganda Force National Development Plan, and a few months after the World Health Organization released the World Report on Social Determinants of Health Equity. It also comes at a time of unprecedented changes in development aid for global health with profound impact on regional and country plans. So that means that we need to do things differently. Because otherwise, if we continue doing it the same way and expecting different results, then Confucius knows well that we are not in the right path. So it has also come at the time of unprecedented changes, recognizing that health outcomes are shaped by a range of factors beyond the health sector, and taking into consideration these changes in the operating context, the conference therefore presents a timely opportunity for a deeper engagement, understanding of the influence of the social determinants of health. It offers space for government, MDS, civil society organizations, CBOs, the majority of the people in this country, the young people, the private sector, the academia, donors and development partners, to collectively identify that what are the priorities and the cross-sectional interventions and the actions to address the social determinants of health and pave way for equitable health for all of us. I hope that the 3 days will be here, will offer innovative solutions, facilitate exchange of learning, and result into a stronger and a sustainable multi-sectoral collaboration that will accelerate our progress towards universal health coverage. I'm looking at that we each of us, individually and collectively, put into place efforts to contribute to the wellness and well-being of first individually ourselves, those in the house. First I want to speak those in the house. So that I have said that so that we practice what we preach. So that if you in the house also practice aspect of good health and you are able to support all this with your families, then we can be able to achieve more. And we shall be able to accelerate our progress in universal coverage despite the dwindling financing landscape. I commend all those who have submitted abstracts and all the speakers for accepting to share political evidence, best practices, experiences, but also the new innovation through a rich conference program which will be shared, and and we extend our deepest appreciation to all the partners, sponsors, those who reviewed the abstract, and the delegations for making this conference possible. We look forward to transformative conversation and solutions that will shape legal and policy framework, programs and strategies and planning decisions, so that we not live here and just that this is just an ordinary conference. We want that we should be able to see that we transform. As I conclude, I want to recognize my co-chair, Fatia Yante, the Executive Director of Senate. She can be outstanding for recognition. I also want to request the members of the organizing committee to just be outstanding so that we can recognize them. I know many of them might not be here. So, ladies and gentlemen, may the conference inspire new commitment, drive bold actions towards improving the health outcome in Uganda and beyond, to move closer to the future, whose sustainable health is realized for all people, especially those who are most vulnerable. I wish you all a very fruitful deliberation. Thank you for listening.
10 o'clock. We officially start off our program. Our sign language for this morning is Olivia Nachigozi. Good morning to you once again, distinguished guests, esteemed delegates and champions of health and human rights, all protocol observed. My name is Priscilla Regina Naloga. It's a privilege to be with you here this morning. I work with Nation Media Group, NTV to be exact, and I'm also privileged to let you know that we are running live on NTV Uganda as we speak. For the next 2 hours, this conference is going to be publicized to the entire globe. I'm deeply honored to stand before you as one of your masters of ceremony. Doctor, thank you so much for those opening remarks from the Ministry of Health. And as the program does continue on, I want us to run a simple exercise, something to engage us and help us understand that at the end of the day, everything around us is contributing to equitable health or not contributing to equitable health. And so I'm going to ask you to engage with me by show of hands. I'm going to share with you some things, experiences that you probably had this morning, and I want to hear from each one of you how you've experienced them by hand, okay? All right, so this morning, how many of you have been able to access this venue by a vehicle or a border? By show of hands. You drove here, you were dropped, you're a dignitary. One of us. Wow. Okay, that's very interesting. Now this shows you that you had to access a road to get to this place. Many a times between 5 o'clock and 8 o'clock in the morning, in the heart of Kampala, you do have our colleagues of KCCA doing some cleanups on the road. This means that you're taking in some dust, right? And that is affecting your health. So the state of your road is affecting your health and my health, and therefore the 45.9 million Ugandans' health that have to use roads. Okay, by show of hands, when you opened your eyes, the first thing you looked for and scrolled through was your phone. By show of hands, guilty. I can't be guilty alone. Organizing team, you had to check those emails to make sure that all these people have to be in this room this morning. So by show of hands, honestly, God is watching us. All right, so now that is mental health right there. How you engage with your morning, getting that gadget, your phone or your laptop or whatever device that you use in the morning, engaging with it, having your mental health shaped by everything that you're going to see on your gadget, be through your social media or your emails. And that alone is also affecting your holistic health. And so whatever you consume in the morning is definitely going to have an impact on the rest of the day. All right, by show of hands, you've had a glass of water or a cup of tea or coffee. I have a cup of water. Okay, those of you that did raise your hands, your health is being affected. So, my dear organizers, can we have, no, there's actually a glass before you and some water before you. Please have that glass of water. Now you see how water and sanitation is also part of this room and part of this discussion and how paramount it is to your everyday being. Now imagine all the 45.9 million Ugandans. And then also, by show of hands, this one is very tricky. Who had time to do exercise before you come in? I'm guilty, don't get mine. 1, 2, 3, 4, 5, 6. Yeah. During the break time, we shall do some doing. But also, the stairs that we have at Still, please make use of them so that you can have your cardio, your physical health well catered to. So ladies and gentlemen, this shows you why you are important in this room for this conference today, the Uganda National Conference on Health, Human Rights and Development. So as we get into the deep of the conversation, of course hosted by the Ministry of Health, from whom we've had opening remarks, now we want to hear from the other hosting partner, and that is SEHAT. The Executive Director, Center for Health, Human Rights and Development is before us, ladies and gentlemen. Ms. Fatia Chianti is definitely going to be giving us something of what she has been able to experience from her line of work. What has she seen on the ground? What has been the experience of community engagements that they've worked with? What have been the results? What have been the studies and surveys they have conducted and SEHAT? What are the realities that we must deal with collaboratively as different entities, different organizations, different ministries, departments, and authorities in this room this morning? Fatia Chiange is the Executive Director for Center for Health, Human Rights and Development. This is a non-profit organization and it is based in Uganda. She has an experience of over 20 years of advocacy work, experiencing for social justice and of course health and social protection systems, and also has had the privilege of focusing on the most vulnerable and marginalized people. She has also worked at the national, regional, and global level. She is a patriot of public health and social work, and her approaches to health rights issues have actually complemented the human rights best approach towards social justice in health and also social protection systems. And so with that experience, ladies and gentlemen, we want to hear from the horse's mouth. Why is it important for all of us to be in this room?
Good morning to all of us, dear delegates. Thank you so much, Priscilla, for the kind introduction. I appreciate it. Allow me to stand on the protocol already established by the Masters of Ceremony, but also allow me to just mention the representation from government ministries, departments and agencies that are here. We do have more than 15 government ministries, departments and agencies. Allow me to quickly mention them because this is important for our conversation on social determinants of health, a conversation on bridging other sectors to realize equitable health for all people. So we do have with us Minister of It. Kindly, if the representatives are here, I'm requesting that they stand up for recognition. We do have representatives from the Ministry of Education and Sports. I know that Angela was running late and her team, but I know she's going to even be on the panel here. But we were with them yesterday in the Youth Town Hall, and I'm sure they're going to be here. We have the Ministry of Water and Environment. Have they come yet? Yes, we have Water and Environment here. Thank you so much for coming. We have the Ministry of Finance, Planning and Economic Development. We expect the Director for Budget, Mr. Huntington Ashawa, will be here on the panel. We have Minister of Gender, Labour and Social Development. I know they confirmed that they are going to be here. Minister of Local Government. We have Minister of Local Government behind them. We do have Minister of Works and Transport. Works and Transport, they confirmed they are going to be here. We have Minister of Agriculture. They too confirmed. Minister of Trade, Industry and Cooperatives. I think they are not yet here, but these ministries all confirmed that are going to be here. We have the judiciary represented. We have the judiciary represented. Yes? Minister of Justice. Yes, Minister of Justice is represented here. We have Office of the Prime Minister. I know they are running, yes, we have Mr. Walugembe here. He's in charge of coordinating all government sectors in Office of the Prime Minister. We have the Ministry of Health, of course. And then we have the Parliament. Thank you, Honorable Member of Parliament. We are supposed to have Equal Opportunities Commission with us. I think they are not yet here. And the Uganda AIDS Commission. I think they are not yet here. And then several universities. So I just wanted us to recognize the MDAs that are here. We also allow me to recognize that we have a representative of the Ministry of Health from Kenya. Yes, Kenya Ministry of Health is here with us. So as I requested earlier, allow me to stand in the protocol earlier established. I know we have the trustees of SEHAD and the board of directors, and they will be speaking to you just after me, but I recognize their presence and support. Dear delegates, the Center for Health, Human Rights and Development SEHAD is honored to be hosting the second Uganda National Conference on Health, Human Rights and Development, UCHD 2025, UCHD 2025 with the Ministry of Health. We join the Ministry of Health to welcome you all to the conference, and a special welcome to colleagues and partners coming from outside Uganda. We have colleagues from Kenya. Those from Kenya, please stand up for recognition. Thank you so much for coming to this important conference. We have colleagues from Tanzania. The team from Tanzania, please stand up for recognition. We do have a team from South Africa. Yes, thank you so much for coming. This is an exciting time because we are here in the same month 2 years ago for the inaugural UCHD 2023 conference, which was still co-hosted by the partnership, Ministry of Health and Center for Health, Human Rights and Development. We thank the Ministry of Health for this trust and confidence in a civil society organization like us. Allow me to just briefly say something about SEHAD. SEHAD is a mainstream legal on human rights indigenous non-government organization established in 2010 to pioneer the justiciability of the right to health in Uganda and East Africa, but with regional and global impact, global contribution and impact. We address social injustices, inequalities, and health rights violations in health systems, and also other sectors which impact the health outcomes for girls and women and other vulnerable communities. This organization advances health rights of vulnerable communities using tested approaches like litigation, advocacy, research, empowerment, and social movement building to realize equitable health and human rights for all people. Our interventions are implemented at national, subnational, community level in Uganda, and sometimes we support work out of Uganda, especially in East Africa. We seek to impact laws, policies, health practices and services, and change of social norms and practices which impact negatively on the realization of the right to health. I know that the keynote will elaborate the right to health a bit further. We strongly believe that a more equal and just society enables individuals, community, and communities to thrive and realize their full potential, and this is critical for sustainable development. So if we are to talk about any development, it must be that development where individuals can realize their full potential. We are committed to advancing social justice and human rights and health for all people, with particular attention to the most vulnerable. Our strategic areas of intervention cut across sustainable access to justice, advocacy for equitable health as a strategy and driver for sustainable development, community and partner empowerment, research and knowledge management. These are further elaborated in our ambitious 10-year strategic plan 2025-2034, which we are going to launch as part of this opening ceremony today. Dr. Laro gave you the background about the UCHD, and right from 2023, where we had 335 delegates here deliberating on the right to health. We had an outcome document from that conference, and the Ministry of Health, supported by all these delegates, made 17 resolutions. These resolutions, I can go through just a few of them, but there were 17. One of them was for the Ministry of Health, and indeed partners like SEHAD and others, to provide leadership for an integrated and multi-sectoral approach, which recognizes the intersectionality between SDG 3 on good health and well-being, human rights, and sustainable development goals. Also, there was a commitment to strengthen collaboration across all sectors in advancing the right to health. There was a commitment to advocate for health in all policies, strategies, and programs, and to effectively integrate the health needs of the marginalized and vulnerable communities, including the youth and persons with disabilities in their diversities, in all programming and interventions, health, education, gender, social protection, among others. There was also a commitment to increase the generation and utilization of evidence in planning and implementation of health interventions, including social determinants of health. There was also a commitment to promote innovative approaches that aim to facilitate equitable access to healthcare services, including social and technological advancements and self-care. With more than 15 government MDAs participating in this conference, together with other key players, with the shared goal of realizing equitable health for all people, we have no doubt that this commitment and actions for implementation of multi-sectoral approach to address social determinants of health are going to be fast-tracked ahead of 2013. Social determinants of health, as Dr. Laro elaborated here, are reported to account for 80% of health outcomes of people, which is why we must be concerned about them and take collective action. Through our work on health policy and the law at SEHAD, including our response to health rights violations, we witness the influence and impact of social determinants of health every day. Let me share just one example we will all remember. The explosion of Chitez landfill in August 2024 and its impact on families and communities, including loss of lives, was an issue of waste management disposal, which is outside the health system and truly something that is a social determinant of health. So why the UCHD 2025? Dr. Laro shared the objective of this conference. I'll just elaborate a bit more of the different objectives. We want to facilitate a deeper conversation of social determinants which influence health outcomes and identify priority interventions and actions to address these. We want to explore the roles and responsibilities of sectors beyond the health system in advancing UHC and indeed the right to health. We want to develop a joint plan of action to address social determinants of health for sexual and reproductive health and rights, for non-communicable diseases, for neglected tropical diseases, and communicable diseases. And those are going to be the tracks or the focus of this conference. We want to showcase successful cross-sectoral collaborations and their transformative role in improving health outcomes of people. We hope that this conference will inspire sectors of government and other key players to put the health of the people at the center of their policy frameworks and programs and contribute to solutions for addressing persistent health challenges and barriers in the country and also in our neighborhood. This is because many of these barriers and persistent challenges directly contribute to health outcomes, and these are underlying determinants of health. We also hope that individuals, families, and communities will be empowered through the different sectors, not just health sector, but through the different sectors, to take an active role in their own health, which is why Uganda is one of the championing countries for self-care, for health and well-being. And we thank the Ministry for championing that and for providing leadership on the continent. We thank all other partners that are also championing this work in the country, including the National Self-Care Expert Group, and members of that group are here too. This conference is only happening the second time and has attracted delegates from our sister countries, as I've already introduced them. This demonstrates its potential to evolve into a regional health, human rights and development conference that will facilitate South-to-South learning, as all countries currently are looking for strategies to realize UHC, human rights, and meaningful development. The release of the WHO World Report on Social Determinants of Health Equity and the operational framework for monitoring social determinants of health equity earlier this year in May, came along with the preparations of this conference, and for us it's an indication that Uganda is yet taking a leadership role on addressing social determinants of health on the continent. I am optimistic that we are going to have an honest, impactful, and actionable conversation that will be sustained beyond the 3 days. I want to appreciate the Minister of Health for the partnership, all government MDs present, and also having been able to dedicate time to this event. I want to appreciate all our donors and conference sponsors, but most importantly to all of you, the delegates, for these 3 days, for allowing to come and we have this very important conversation that drives our health and development as a country and also as a region. I want to appreciate the support from our trustees, our board of directors, and the entire staff team of SEHAT. My team, can you please stand up for recognition? Some of them are outside busy, but at least I know some of them are. Allow me at this point to end my remarks by inviting the board of directors, the chairperson, board of directors of the Center for Health, Human Rights and Development, to give you very brief remarks. Thank you so much for listening to me, and we look forward to an exciting convening. So Mr. Akram Zua here is the chairperson, board of directors of the Center for Health, Human Rights and Development. He's a finance expert, he's an economist, and he's also a senior lecturer.
Good morning, everyone. Allow me to thank the Executive Director for inviting me to give an opening remark in this year's conference, the Uganda National Conference on Health, Human Rights and Development. I thank Dr. Olab for your opening remarks, and I want to stand here on behalf of the Board of Directors, just also to welcome you, but allow me to, for those of us that have just come in, to go through the protocol again. The Right Honorable Prime Minister in absentia, we are likely to have a few hours from now as our chief guest. Officials from the Ministry of Health, the State Minister, Honorable Margaret Mohanga, we expect her to be here with us. The Director General of Health Services, who's been here before, that is Dr. Oral Charles. Dr. Kasonde Muhinga, the representative from the World Health Organization. The Executive Director of the National Planning Authority, Dr. Mvawala representatives from government ministries, departments, and agencies are available. As the previous speaker said, we have so many collaborations from the ministries, and they are with us today. Representatives from the Ministry of Health in Kenya, the representatives from foreign missions, Uganda National Conference on Health, Human Rights and Development. This is the second one after the inaugural first conference, which was held in 2023. And with your support as delegates, we are welcoming you again to this second Uganda National Conference on Health, Human Rights and Development. A few years ago, when I say few, they may appear few, but they're 15 years ago, SEHAD was banned. And we shall have a slot in this conference to also celebrate for the 15 years of existence. A few lawyers, who were very young by that time, led by Dr. Mumba, who is present here, gave birth to this organization called Center for Health, Human Rights and Development. And along the way, we have built it to this level where we have also attracted the Minister of Health in trusting that they can hold a conference with us. So we have a very strong governance structure, which is led by the Board of Trustees. And allow me to take this opportunity to introduce our Board of Trustees, those who are present and those who are absent. It is being led by Professor Ben Pinomogisha. Professor Ben Pinomogisha is stand up recognition. Chair of the Board of Trustees, and being deputized by Professor Segale MCC. I don't know whether he's around. Then we have Dr. Moses Mulumba, also part of the Board of Trustees. We have Ms. Jane Narunga. We have Mr. Mark Tumwine, and also Professor Kasimba Zemana as members of the Board of Trustees. And then the Board of Trustees put us in place at the Board of Directors. And I take this opportunity to introduce also the members of the Board of Directors, being chaired by myself. And you have Ms. Agnes Girabo as the Vice Chairperson Board of Directors. She's a food activist, food rights activist from the Food Rights Alliance. Then you have Mr. Jonathan Cheyune. I think he'll be joining us very soon. Then you have Dr. Senisui Mosoke, a retired medical practitioner. And Ms. Penelope Sanyu, a feminist and human rights activist. I think she'll be joining us very soon. Along the way, we had to support the Secretariat, which we strategically guide on running the organization to develop a new year, a new 10-year strategic plan, which will be running 2025 to 2034. And we shall also have the opportunity to launch this new strategic plan in this very conference in the 3 days that we're going to be here. Allow me also to mention this, that with the support and collaborations from the various ministries, departments and agencies, our donors, development partners, and the people we serve, we have been able to reach at this level of ensuring that we have equitable health for all. And it is the reason and the basis upon which we are holding this conference alongside our partners, that is the Ministry of Health be our home. Feel free, interact with one another. When Priscilla here announced that how many people exercised this morning, I felt guilty because I did not. So I wanted to run when I was coming here on stage, but you allowed me as I leave this stage to run a bit to be able to exercise. And I call upon everyone to participate as much as they could in order to realize the objectives of this conference. I thank you so much.
Let's clap like we mean it. Thank you very much, the board chair Sehat, for those remarks. I will give you another quote, and it's from Paul Farmer. He's an American anthropologist and physician, and he said, if access to health care is considered a human right, who is considered human enough to have that right? I hope by the end of this 3-day conference, we'll be able to answer that and take into account this quote from Paul Farmer. We are going to have a brief interlude, and I hope the team that is giving us the interlude is ready, and that will be ushering us into the other segment of this conference. And I wish to ask everyone to clap for ourselves for having attended attentively through the opening ceremony of this ritual. So allow me to invite a peer educators group from West Nile region to give us a brief interlude. Thank you. Do we have a movable microphone?
Okay, good morning, esteemed audience. I observe the protocol and the distinguished capacities. Before you is evening Fiona, a peer educator from Marua City, that is under West Nile region. And I haven't come here alone, we're in a team, so we work under a stand-up project. Normally, when we reach out communities, we do a play role where we bring in situations and we engage in dialogue as we sensitize the community. So, we are basically here to perform a skit in relation to the theme of the conference. So, our title is Bridging Service Delivery Gaps, Building Health Systems Beyond the Clinic. So, I'm going to narrate the skit as it transpired. So, I'll start. So we need to know that in every community, health is more than just taking medicine. It is shaped in conditions in which we live, our homes, workplace, schools, and the communities. So in the skit, we meet Sarah and James, whose conditions reflect how underlying situations of non-medical conditions significantly influence the health outcome. So that is the narration on the skit we are going to perform. Therefore, I declare the first scene open.
This life of balance. I've suffered. Ever since the factory have been closed, there's no one moving up and down. Oh God, my family, my wife. Oh, Sarah. Sarah, how are you?
James, I'm not feeling well. James, I feel very weak. I think I need to see a midwife.
haven't found any work opportunity. Even we barely have food stuffs in the house. How then can we pay for the hospital bills? Let us go and run up and down and see something. Let me come back.
Okay. That is the first thing, and in relation to that, means out of pocket expenditure and unemployment, which are the two powerful determinants, already stand in the way of Sarah's access to health care. Such factors are increasing the disease burdens on many households. It is also important for us to have interventions such that people can access healthy services from our health centers without any financial hardships or poverty, which involves high costs. That is basically the first thing, so the second thing can resume.
Sarah. Thank you, Sarah. This time you missed your antenatal visit again. What happened?
I couldn't travel. I don't have any shingle 50 coin inside this house. And the roads we are having are very bad. And the health center is so far.
Oh, sorry, Sarah. I understand your condition, but it's not really okay. Your condition may become complicated. It will be so hard for us. You need to make it to the health center. I think by next week, I need to see you at the health center. Is it okay? It's okay, fine.
Okay, concerning this thing, we have beyond poverty, social norms, and fear of discrimination gender. There are also socio-cultural factors which are affecting Sarah's health-seeking behavior. So that is what is taking place. I request that you continue with the scene.
Good morning. What is going on here?
Thank you, Elder. I came to see my fellow woman because I've seen she's going through a lot. I came to advise her so that she could really make it to the health center. Because her being at home here, just getting seated, just doing nothing, not visiting the health center is not okay.
Why are you people always focusing on health centers? When our women used to produce at the home, I'm used to helping with our traditional arts.
I know, Elder, during those days, we used to have those herbs. But let me say the present condition we are in, she needs to visit the health center because relying on those traditional norms will continue to take us backwards. It's not really fine. She needs to visit the nurse at the health center.
Since you can't understand me, let me take my leave.
It's okay, you can leave. But Sarah, my advice to you is next week your husband should accompany you. You should go and visit the nurse at the health center.
So concerning the whole scene, this scene too, mean barriers to health-seeking behavior. They go beyond financial costs, limited access to facilities due to distance, or lack of service to include socio-cultural factors like fear, gender roles, lack of knowledge, and there are also other individual psychological factors, fear and shame, alongside systemic issues like poor quality health, complex health systems, and distrust in service providers, which hinder many people from seeking timely medical help. So that is basically on scene 2, then scene 3 can start.
Let me take you to the hospital. No, we don't have money. Please stand up, let's go. It's not transport. Slowly. Let me carry my bag.
can see how to handle them. Is it okay?
Thank you, Amina, for bringing for us this information. We shall see what to do.
Thank God we come at the right time. My wife has been suffering, please attend to my wife. Though I don't have money, please, I beg you, attend to my wife.
Sir, we don't have enough medicine here. Maybe you can first and we don't have enough medicine. The facility is overcrowded. This is the end of, sorry Sarah, take her. This is the end of C3. Means in community health systems, they encounter several challenges, which includes insufficient human resource, particularly in rural areas. We also have shortage in funding, leading to fragmented and under-supported programs. There are also other gaps, which are related to integration, with poor coordination among service providers, weak referral pathways, and lack of supportive policies, training, and reliable health information. Additionally, systemic inequities also hinder many people from accessing minimal service package, while community health workers face barriers to full integration into formal healthcare structures. So that is what has happened in scene 3. We are now coming to the last scene, which is scene 4. I therefore request the action.
I've not seen change. I think it's high time I started mobilizing the community members to see what's really going on here. We need to go and settle this issue out. Because what this young woman is passing through is not something easy. Thank you. I welcome all of you. I am the village health worker. I want us to come and settle this issue out. Because last time I visited the health center, I've not seen change. And I think I want to give this opportunity to this young man to speak what he really has for us.
Thank you very much for giving me the time. I've learned a lot in this life. If so, unfair wages or the riches, I will feed my family and not a health. Does not wait for money. That's all I can say right now. Thank you.
My dear, thanks for coming. If my first sit down, leave me. My dear members, if maternal services were closer, affordable and welcoming, I would go without fear or doubt. Thank you.
Proper support and investments. I can give safe care and restore trust in our health system.
Now from here, on the south side, I think we are going to
Thank you everyone for coming. Thank you for coming to solve our problem.
Doctor, thank you. I've taken all your notes. If local leaders and partners, this is
the spirit UCHD 2025, bridging gaps across sectors to achieve equitable health for all. So this marks the end of the speech, but we still request for your attention as we continue with the entertainment. Thank you so much for the audience.
A round of applause for this team. And we will have a good.
Allow me to invite Miss Angela Nasuka from the Gender Unit, Minister of Education and Sports. Angela Nasuka, please join us. She deserves some. Let me take this opportunity to invite Miss Prebaze Julia Elias, Senior Social Service, Minister of Water and Environment, WASH Program, Minister of Water and Environment. That's not good enough, members. I know the night in the morning, not all of us had a cup of tea, but this energized presenters, our panelists. I'll be happy, shall be joined by Miss Agnes Crabo, online, Executive Director of Food Rights Alliance. Ladies and gentlemen, ladies and gentlemen, before we came in, we had a skit, and there's one statement that I had and which I want to share with you. And this is that good health begins before one walks into the health center. May we kindly clap for that team that presented that skit, which is educative and shows a lot of connectedness that we desire to drive health outcomes. Ladies and gentlemen, I work in terms of the Prime Minister, Department of Strategic Coordination and Implementation, and our role is to ensure that government works together in a connected way so that we can drive and achieve the outcomes. We note that, again from the skit, no single entity, no single agency can give us the results, but when we all work together. So the social determinants come into play. So allow me now, ladies and gentlemen, to Mr. Edwin Wangira, and he's going to give us his reflections on the health needs of young people, more so those in the remote settings. And the point is, what factors are determining whether they have good health or not? Mr. Wangira Edwin.
Yeah, thank you very much. I'm proud of observe. My name is Wangira Edwin. I'm a educator from Namaingo district. I'm humbled to be part of this very wonderful conference. And briefly, allow me to talk about Namaingo as a district. Namaingo is located in the eastern part of Uganda, in Soga region. Namaingo as a district consists of 8 sub-counties and 3 town councils, of which 3 of the sub-counties that make up Namaingo district are totally in the island. 4 of the sub-counties border the shores of Lake Victoria, and so it is one of the factors that makes my district Namaingo to be so in remote areas. I want to discuss some of the factors that are making the health of young people living in Namaingo to be very, very bad. And I would like to tell the House that Namaingo as a district, we are geographically located in a very, very unpositive manner. First and foremost, allow me to go lack of health facilities in my district, Namaingo. We have sub-counties of Lodway, whereby we only have a single health center in the great sub-county. Lodway as a great sub-county of Namaingo has got a very big population, both of young people and adults, but with only one health center and that health center is located in Kandege. But Lodway as a sub-county has got very many other parishes. Of course, it consists of 5 parishes. And these parishes are far away located from each other. So this has made the health of young people so difficult in my sub-county of Lodway. Remember, in those islands, we have very many infectious diseases. And the health, now depending on that limited number of health facilities, has now become a very big threat. And secondly, the distances to the health facilities is very far. And also the transport costs. You find that a particular person traveling from, let's say, Kandege, and to go to Lodway Gorofa, a border guy will ask for someone to pay almost 5,000. And the situation on that side, the financial situation is really unfriendly. So our people are ending up dying simply because of lack of transport and long distances to the health facilities. Some areas in some other sub-counties, let me mention a sub-county like a Banda sub-county. Banda has got no health center 3. It has only health center 2s. Yet it has a huge number of people living in that particular sub-county. So our fellow younger people who are yearning for services, like testing for STIs, family planning services, ends up not getting those services simply because they don't have the nearby facilities to support them. And the other factor that we look at in Namaingo that is also hindering the health of young people is lack of youth corners at the health facilities. Given the few health facilities that we have, most of the health center 3s in Namaingo district don't have youth corners. And now these young people, at most times they even fear to express their privacy with those grown-up people. Youth end up going back without telling the physician what his or her problems are. So we request that maybe if there might be a possibility of our people getting those youth-friendly corners at those health facilities, it would favor the health of young people. And also the other factor is poor education system. In Namaingo district, we have some counties that don't have even a single secondary school. Lodway as a great sub-county does not have even a single secondary school. And remember, it is an island. So for someone who has finished his or her primary education, to only get the secondary education has to travel from the island to the mainland. And yet it is very costly. Yes, we have the ferry there, but the ferry does not move on daily basis. It has its days of work. So our young people ends up not going in for school simply because they don't have that chance of the schools in their respective areas of residence. And the other challenge is also health literacy. In those few areas with health facilities, more so health center 3s, the health workers seem not to have even time for educating our patients, the clients, for providing them with health knowledge. That task is left for peer educators and some CBOs. Like in Namaingo, we have a CBO called Namaingo Youth Forum. That CBO has got a good number of young youth. They move around the health facilities, educating young mothers on antenatal, on the spread of STDs, on how best they can breastfeed their children, and so on and so forth, and even family planning. So now, given the fact that we don't have those health literacy sessions at our facilities, it has created a very huge problem, more so in the illicit sector for the young people in Namaimo. We also have poor support in recreation activities. Remember, with the young generation of today, we are much more engaged in recreation activities like football matches, these traditional dances, and so on and so forth. But we don't have people who can support in that area. Yes, I want to thank some of the partners, like Sehad, yes, I'm just finishing, like Sehad and Oxfam. They have been so supportive in that area, but not to the extent that they are covering the great district of Namaimo. This sports activities captures a very huge audience for even us educators to spread our gospel of health to the people. And lastly, and lack of youth centers in our district. Namaimo as a whole district, we don't have even a single youth center. This youth center would have been very important to the youth of Namaimo or in another district. When they go there and do their businesses as youth, as younger people of this generation. And now we as the young people, we cannot forget to advocate for that in case there is chance. I know we have very, very important people in the house who can help us in that area. And let me thank you, and I leave there. I make one Edwin and be an educator from Namaimo this week.
Let us go to Ms. Angela Nasso. Less than 5 minutes. Please share with us your view on what the education sector is kind of doing to contribute to a healthy and productive population. I have had a second response in Lorry Island, but also tell us what more the sector can do to accelerate the realization of the vast progress coverage by 2030 and Vision 2040. And what will this be? 5 minutes.
Thank you, moderator, and I am humbled to be here today. As the Ministry of Education, our key focus is to have inclusive education for all, which is key in influencing the health behavior and the ability to access health care within the different levels. As education, in contribution to the key focus area today, I would like to state that, for example, the ministry passed the early childhood and care education policy, and this is something that is critical for us, especially because it is at the foundation. If we must look at the social determinants, then education is one of them, and therefore we need to look at the different levels. At the early years, we believe that a child needs to be nurtured, they need to have good nutrition, they need to be protected, their facilities need to be well catered for, and definitely they need to learn. So that is key, and the Ministry of Education and Sports has undertaken that role, much as we are working with the private practitioners. But we have leveled the ground to set the policies, to set the guidelines, and the other implementation mechanisms. And when we look at, for example, the other level, the primary and secondary, we do have the universal primary education and the universal secondary education. For me, I feel that is a plus. From a point of where we did not have many of our girls going to school, to date we see many of our girls going to school. The key issue here is the challenges that actually affect them, like the teenage pregnancies, the child marriages, and issues to do with menstrual health and hygiene challenges. But as a sector, we have come up to set key standards to be able to support the retention of our learners schools. We do have an interministerial committee that is led by the permanent secretaries for the Ministry of Health, Ministry of Gender, Ministry of Education, the local government, and the Ministry of Justice. And these are key in making key decisions, deliberate effort in dealing with issues of teenage pregnancy so that we are able to retain our learners within the school setting and also improve the learning outcomes at the end of the day. We know that there are social cultural norms and practices like the FGM, the early and forced marriages. These are also being handled by the different sectors and in line with education. Because for as long as these are happening, then we have less learners within the school setting. But I want you to say that as a sector, we have already attained gender parity. The issue here is how do we retain the girls within the system? How do we have the learners with special needs in the system? I am glad to say that in the previous financial year, the budget for the learners with special needs was increased. Better facilities for the learners with special needs, better learning materials that are brailled, better hearing aids for the learners still with special needs with hearing disability. So we believe that government has made strides. And when we look at issues of sexual reproductive health, the government has reviewed the sexuality education framework, and this process is still ongoing. However, the name has changed to the National Framework for Education for Health and Life Skills, so that we have grounded learners with key life skills and values attained at the end of the day after the acquisition of the age-appropriate information. The government has gone ahead also to say, can we support the learners that have dropped out of school because of teenage pregnancy or any other reason, come back to school? And we have seen many learners come back to school as government and have continuously engaged the communities. We are saying that by engaging the communities, we shall possibly also improve the parenting norms of the parents, because we know that that is our weak point, and yet a very strong unit, because the children come from the community, they come from the family. So if the family has violence, for instance, this is going to trickle down to the schools, and we feel that as Ministry of Education and Sports, we have moved strides on that. We are also seeing that we are vocationalizing education much more, because we want our learners to get out of the system with a key skill. For example, the vocational courses that the learners are doing within their schools, which are examinable. By the time this learner goes out of school, they are able to have something, a skill that they have gained at the end of the day, especially with the new curriculum. We are seeing more health training institutions being supported by government. As government, we have 20 health training institutions, and these training institutions actually support more than 1,000 learners. That is for diploma and certificates. And where are these ones going? They are also contributing to the health population. So we believe that government is not seated, but trying to make strides to improve the status quo so that we socially, economically contribute to the progress of this country. The school loans and bursaries, these are also key, because it is mostly supporting the learners that are taking on STEM and ICT. And we believe that this reduces on the gap. People were saying, we have more arts learners, where are the scientists? So the school loans are actually supporting the scientists to come more on board. Oh, thank you.
As well as environment, as a drive affected health from major insights there. And also we shall need to know what have been some of the best practices. Let me cut it into after that. Kindly, for clarity, your experience in utilizing clean water, sanitation and hygiene, wash and coal, as well as clean environment as a driver for equitable health in Uganda. And what are some of the best practices?
Thank you so much. I'm called Trevor Secretary Immediate, Civil Sociologist, Ministry of Water and Environment, and a focal point officer for nutrition and food systems. I bring you greetings from the Ministry of Water and Environment, especially from my permanent secretary, Dr. Alfred Otokede. Ministry of Water and Environment, we have a mission to promote and ensure that the rational, sustainable use and development and effective management of water, environment resources, and socio-economic development of this country. My question is on the experience of utilization of clean and safe water. I will start by giving you that, by telling you that in 1986, I can start the experience from 1986, water and sanitation we were around 20%. 20%, the country was really doing badly. But in the 90s, there was a deliberate effort to increase the water coverage from 20%. So we had projects, some of you maybe had them from WASA, we had projects like Southwestern Project, we had very many projects. And from that time, the coverage increased to 50%. But in 2010, around 2010, the coverage continued increasing, where we had the World Bank coming in to give support, we had ADB and other projects to come in. So we increased it up to 70%. Currently, we are around 70%. But all these efforts were aiming at increasing access to safe water, but also reducing the disease burden. You all know the water-related diseases, the water wash, the waterborne, the water-based diseases. All these diseases were affecting our country before 1986. But after that, together with Ministry of Health, we worked hard and we improved. Personally, I have been in over 80 districts promoting and creating awareness, but where we have a water supply system. So we have to bring all the sectors together to work with them. We had to create this environment where all the NGOs come together, we plan together and implement together. So as I talk now, the health system, as I can say, people are aware of what to do. They know sanitation and hygiene, they know the causes, because we have created a lot of awareness. We can see people also connecting to the water supply systems. Initially, as I told you, it was like 20%, but now we have very many people connected to the water and sanitation systems. To give an example, before we used to have the local government managing these water supply systems, but as I talk now, the national water is managing over 200 water supply systems, and we have another organization called Umbrella also managing over 200. So as you manage the water supply systems, as you construct them, we have time to go and explain. The ministry has recruited the social scientists, has recruited environmental health officers, and these environmental health officers are in charge of resource protection, they are in charge of environmental management, so we are doing great. So as we talk of Ohinde being aware, you will realize that during COVID, for example, the disease burden, people are not visiting hospitals. Why? They were just washing their hands, meaning that the communities are aware of what to do. And also, we have realized that we have very many mushrooming factories. Those factories are here because we have water, because they have water. We have seen private sector coming on board to do, for example, fecal sludge management. We have seen private sector also coming in to do solid waste management. Someone has talked of UCHD, yes, but we have also private sector. That one maybe I will explain when we go to what much do we need to do to promote this. So we have seen very many private sector in solid waste, because solid waste is a challenge here. We have seen them in fecal sludge management, and we have seen them in water. These are all water bottles. We have people doing it. We have people interested in selling water. So people are aware the importance of water. And for sure, those who are not taking water, you can take a sip. It is good for your health. The best practices, thank you. The best practices, one, collaborations, working with other sectors. We've worked with KCCA, you will see all those trucks written on US, they were donated by Ministry of Water. We've worked with the local government, that's where our people are, that's where our community are. It is the best practice. We've worked with the Ministry of Health, we've worked with the Ministry of Education, especially sanitation. So all those are good best practices. The NPP4, I can see it here, it also brings together, it is a good practice. We have also those O&M structures. During the time for the private sector and local government, most of the water supply systems were down. Why? Because of electricity, they were down because of the workers. But now we find we no longer have water supply systems which are under key and low for like 3-4 weeks. Quickly the operators can work on that. So these benchmarking exercises, we have also the best practice in the benchmarking exercises. This was crucial because we help in learning. We have the sanitation marketing. Most of the toilets collapse when you use the cesspool emptier, but now we are doing sanitation marketing and we are constructing fecal sludge management treatment plants. This one is happening both in rural, the sanitation and water supply, we do both in rural and urban areas. For the time being, I think I can stop.
Thank you very much. Yeah. We are going to hear from Agnes Kerala. She's the project. Can we get Agnes.
Thank you so much, and I wish to recognize and understand on all the existing protocol as it has been observed since we started. I'm happy and I wish to congratulate the Ministry of Health and your partners, Center for Health, Human Rights and Development, and all our development partners that have found it fit to support this second national conference on health, human rights and development in Uganda. I wish particularly to congratulate the Ministry of Health and your partners for specifically setting aside this conference to discuss the social determinants of health. A fondly neglected aspect of our health systems, and yet part of the philosophical foundations of health tells us that prevention is always better than cure. But more often than not, conversations about strengthening our health systems are always focused on the clinical and the infrastructure perspective of health. People are always demanding for health facilities, which is structural. They are demanding for health workers, which is human. They are demanding for medicines and drugs, which is the clinical aspect, all put together. And rarely do we discuss the social and the underlying determinants, of which if we could only address such, we are going to keep millions of people out of the health systems. Actually, the resources that our health system in Uganda is having currently now would be more sufficient for our health system if we could only address the social and the underlying determinants of health. Our health workers will be spending a lot of their time in research as opposed to attending to us. This morning, I wish to address myself on the two perspectives of the social determinants or the underlying determinants. And the first of it is the politics. The politics of the politics in the world that is causing a lot of anxieties and mental distress. And we all know how we are not doing well as a country in as far as mental illness is concerned. Official statistics tell us that 10% of the total population in Uganda currently, and far more than that, in one or the other, are suffering a form of mental distress. And one of the drivers of this is the politics of the day. We all know what is going on currently in the country, how people are so stressed, how people are so distressed, and we don't know what is going to happen after that. So either as active political participants or recipients of the political decisions, politics is pushing many of us into the health systems. That is also accompanied with the economics of the day. So if we could only play our politics right, if we could only deal with our politics in the right manner, many of us may not end up into mental hospitals. I do work on food. I'm a food enthusiast, and food, you want what you eat. That is what we are told. What did you eat for dinner? What have we served our families? What are our children eating in schools? What are we eating? What we are eating is what is pushing us into the health system. Our health system is grown by people because of what they have eaten or what they have not eaten. Look at the numbers of people with non-communicable diseases. Pressure, hypertension, diabetes, cancers, and all the things, they are because of what we are eating. The sugar-sweetened beverages, the alcohol, the chemical residues in our foods. You know, it is what we are eating. The too much of oils that we are eating are the ones that are filling up the Heart Institute, they are filling up the Cancer Institute, they are filling up the Diabetes Clinic, and all of those things. Simply the amount of money our country is spending on treating malnutrition alone. One child requires a minimum of $120, and we are having 26% of our children under 5. And 54% of the population that suffered stunting while they were children. The country is spending $254 million annually to treat malnutrition, foodborne diseases like diarrhea, and respiratory illnesses because of what is happening in our environment.
Thank you. Let me now go back to Julia. Few minutes from that side. What else do you have to tell us?
What else do I have to tell you? I will continue by my experience in 2 minutes, but by saying that the transboundary is also best practice because it brings countries together to protect, for example, Lake Victoria from common good. But also in 2 minutes, I have to tell you that these engineers of ours have a lot to do in this country. So, like Stacey, for example, recently I was in South Korea where I saw they have land, big land, and they go 50 meters underground and they treat fecal sludge and they treat solid waste. But this solid waste gives them renewable energy. We need these engineers to engage them to come and do permeable roads so that we don't have floods. Because if someone is running off from flood, definitely, even if we do not even eat, but also when someone is running out from the flood, these floods come with other issues. We also have refugee influx. This refugee influx, these engineers can plan for this refugee influx. These engineers can plan for our towns so that all the water is collected and is recycled. So we have a lot of work to do, but we need funding, we need the political support, and we need all of you. Otherwise, I will tell you that water is a human right. First of all, water is nutrition sensitive. If you have water, you can take some time without suffering in the hospital. Even when you are born, you need this water. So water is nutrition sensitive. But the waterborne diseases shouldn't be taking us to the hospital. Because they are the majority, and I understand that area kills more children. All those waterborne diseases shouldn't be taking us to the hospital. I thank you.
Thank you. Angela, what else do you want to tell us in the sector?
Thank you very much, moderator. I would like to, highlight that going forward, it is key for us to ensure that we have better coordination mechanisms, strengthen our multi-sectoral coordination, for us to be able to holistically implement our key policies, our key guidelines, our key commitments at the different levels, both international, regional, and national, so that we are able to change the status quo. I would also like to highlight that the implementation of our key policies and guidelines at the different levels do not only rely on government, but also rely on all of us to play a key role to ensure that we make change within our localities. I would also like to highlight that with the PDM, that is the Parish Development Model, it is able to integrate different components, that is on health, education, social development, you can name it. And I can see that this approach is able to improve the accessibility, accountability, and also aligns well with the local government priorities. So much as it has some gaps, we want to also say it is a good approach that we can rely on as a country. And finally, I would like to say that it is key for us to ensure that our communities, our parents are engaged at all times, because they are the custodians of the young people and the children that we have in our midst. It is key that the different grievance redress systems are strengthened and we ensure their functionality. Otherwise, if we talk about issues of management of cases of abuse and the structures are not functional, then we may be wasting our time. Therefore, in a nutshell, every little action counts, and we should be able to look at the different determinants for us to be able to change the status quo. Thank you.
Thank you very much.
Yeah, thank you. I would like to tell the House that the unfriendly policies that the government has imposed on the fishing sector and also mining sector has been key in making the people of Namai go bankrupt. And as a factor, people cannot even access their health simply because they are very, very poor. 95% of the people of Namai have been depending on fishing as an activity as their major source of income, but now the policy of the government, because of fishing, is no longer favoring them, and they are totally bankrupt of that. how I wish the government advises on people on that, and maybe our people might live a sustainable life.
Thank you very much. You stated the challenges, and you talked about, of course, we're talking about fishing policies, but I think we need to add health policies. But, ladies and gentlemen, I'm going to invite Mr. Angela, my co-moderator. If he's not here, I want to thank the panelists for the insights that we got. Can I give them a warm clap, ladies and gentlemen? They made us aware, first of all. And I want to say that awareness is critical, but awareness is not enough. We have to act when we are aware what actions to be taken in order to achieve our outcomes. Number two, I want to observe that each of these sectors are very important. They are necessary for us to achieve health outcomes, but it's not sufficient to have them. They are necessary, but it's not sufficient to have them, but they need to work together so that we can get our outcomes. Number three, the issue of coordination and implementation. I think that is critical. I want to say that from where I sit, I know that we've got very good programs, very good frameworks, which are fit for purpose. Our duty now is to implement them to the letter. Let's look at the quality of implementation and the pace, so that we can achieve the outcomes. All of us have a role to play. None of us can do it alone, the politicians. And I'd like to say that Agnes indeed identified the various stakeholders for whom this conference is intended. And how I wish I would have had a member on this panel from the private sector, because they play a key role. So I want to thank you for your kind attention. I was given to close my session at 11:15, so I'm not going to allow questions, but your reflections can be received. You can go to the Secretariat. So ladies and gentlemen, the social determinants are necessary, and we need to work on them all. We need, as government and all stakeholders, to work together. Health outcomes to be achieved is the whole of society approach. It goes beyond the whole of government approach and goes to whole of society approach. A couple of reflections and insights from various panelists here, which I think have been picked, and we need to take them forward. So I want finally to congratulate Minister of Health and Seha on this second conference. Thank you very much. My time is up.
Think how we are going to engage in the next 2 days. This particular session has a number of people that are going to check where we are at, but also secondly, they are going to challenge us to think beyond what is comfortable for us and also move into the future. I have a very exciting panel that I'm going to invite to come here to be with us for this particular keynote address. And this panel has people that are cross-sector, because like we indicated in the sessions today, we are looking at the right to health, we are looking at health and human rights, we are looking at underlying determinants. And this panel, the keynote address, really looks at an in-depth interrogation and creates an understanding of the nexus between health, human rights and development, and how they positively impact on each other. It will enable us to reflect deeply on the underlying determinants and also ultimately on how health and human rights affects the needs, as well as what collaboration and intersections we need between various sectors, governments, and other key stakeholders. It is my honor and pleasure to invite and introduce the people that are going to enable us to think deeper than where we are at now. Our keynote speaker is none other than Professor Ben Mugisha Kiromba, and many of us call him Professor Shokoro. Professor Ben is a very interesting person whose CV will take us the whole day if we were to read it here. But for purposes of time and to enable you to do your research, given that we also have free Wi-Fi in this room, this is the summary of his bio and also why he's the person that is going to challenge us into the keynote. He's actually a full professor of law and a former dean of the School of Law of Makerere University. He is the pioneer of the Health and the Law course at Makerere University and was created it in the year 2005, that is 20 years ago, and that creates a huge milestone on which we stand. We are standing tall on such an effort. He holds a distinction of being the first graduate to be awarded a Doctor of Laws by Makerere University. And of course, he has authored a book that I know many of us refer to, Fundamentals of Health and Law. Professor Shokoro is going to challenge us, and we are unfair to him because we've allocated him little time. But like we all know, time is never our great friend. After he speaks to us, I'm going to invite actually all the respondents to come here so that we can manage time, because it allows us to be very efficient, but also for them to connect even if it is not by word. The first respondent is coming in from the Ministry of Health, Dr. Joseph Opare, who is the Director of Health Services, Governance and Regulations in the Ministry of Health. And he has supported a lot of work around health systems for the last 20 years. Welcome, Dr. Joseph Opare. Hey people, let's clap. We have everybody as in this room. I know we are holding our teas and mandazi, but let's acknowledge each other in this room. Then the next respondent comes in from the National Planning Authority, and is Dr. Munira Babazi, a senior planner, family health, systems and nutrition from PA. Like we know, NPA is charged with making sure that we are developing integrated development plans, and like we all know, we have an NDP4 which is new. Welcome, Dr. Munira Babazi. And then we have a representative that comes in from the Institute of Gender and Development, Makerere University. Like we all know, there are gender dimensions of health, human rights and development, and we need to have an insight into that. Please enable me welcome Dr. Donna Keironji. And with that, I'd like to invite Professor Shokoro, Professor Ben, to come and give us his keynote address.
You are sure it's working? Thank you, Makawesi, for that presenting us introduction. My wife is Alsacia, along very important persons like her here. I'm not a protocol man, so I'll go deeper into my work. Thank you. I was asked to deliver a keynote address. I prepared I thought I would be given 1 hour. At the last moment, I was told I have to deliver in 30 minutes. So I will try. So the topic I was given is the nexus between health, human rights, and development, the urgency of addressing underlying determinants of health. I have been in this field for over 20 years, both as a teacher, researcher, and activist. As you were told, I'm the chair of the Center for Human Rights Development Board of Trustees and Apia Lahak, and we engage in health issues daily. In 1946, as we all know, the WHO defined health beyond health care, beyond the biomedical approach, as a state of complete physical, mental, and social well-being, rather than mere absence of disease and infirmity. So way back during that time, when Uganda was under colonialism, the WHO felt that health cannot be viewed in terms of medical care only. We must look at the underlying determinants of health, be it economic, social, security, sovereignty, health, resources for health, governance, etc. As we know, human rights are supposed to be inherent, universal, applicable to all, and enjoyed without discrimination. In the human rights language, we say the government or the state has an obligation to respect, protect, and fulfill human rights, including the right to health. Governments like Uganda have an obligation to ensure the availability, accessibility, and acceptability and quality of healthcare goods and services to all, without discrimination as to class, nationality, ethnicity, sex, sexual orientation, and other variables. According to the Committee on Economic, Social, and Cultural Rights, the right to health does not only require timely and appropriate health care, but goes into underlying determinants of health, including safe and potable water, adequate sanitation, supply of safe food, nutrition, and housing. I have a long paper about 20 pages, but you see I'm moving on the pages as we move. This committee further observed that the right to health should be observed by the states in terms of its individual and collective dimensions. And the right to health does not mean the right to be healthy. You can't say eat pork or muchomo or other red meat and junk food, and or abuse alcohol and other substances, smoke a packet of cigarettes daily, lead a sedentary life without regular exercise, or have unprotected sex with multiple partners, and when you fall sick, you seek to hold the government accountable. I can assure you, you may not succeed. We have obligations to take care of our own health. The government may already be obliged to provide relevant health information and education on these products and their link to non-communicable diseases. But the responsibility to ensure your life is on you. Your health is on you. What then is development? Will you permit me to read part of this and as I speak to the others? Development, in my view, is a complex and fluid concept. There is no simple, universally accepted definition of development. People may have different answers depending on whom you ask. Cambridge Dictionary defines development as a process in which someone or something grows or changes and becomes more advanced, close quote. Some people talk about economic development, political development, social development, human development, and as we see recently, sustainable development. I got a book I used in high school from my old shelf by Todaro on development economics. He defines development as, I quote, a multidimensional process involving major changes in social structures, popular attitudes, and national institutions, as well as the acceleration of economic growth, the reduction of inequality. And when we talk about inequality, it's social, economic, good in gender, and the eradication of poverty. According to him, there are three objectives of development: raising living levels through economic growth, creating conditions for self-esteem, and expanding freedom of choice. Building on freedom of choice, Amatia said in 2000, views development as, I quote, a process of expanding the freedoms that people enjoy, close quote, which requires removing barriers to freedom, for example, poverty, insecurity, and accountable government, and tackling the lack of infrastructure that complicates physical mobility or a lack of access to safe drinking water, food, or electricity. Another scholar called Hugo views development as, I quote, essential about change, not just any change, but a definite improvement, a change for the better. At the same time, development is also about continuity, because if change is to take root, it must have something in common with the community or society in question. It must make sense to people and be in line with their values and their capacity. Development must therefore be appropriate culturally, socially, economically, technologically, and environmentally. And don't worry about the panel meeting, the discussants. We tried to give them about 80% of the summary of these papers, and they'll be able to contribute. Development can therefore be taken to mean some kind of progress that happens over time. But one thing I would like to emphasize is that we should not confuse development with growth, economic growth. I hear African governments and other governments celebrating when they talk about 6% growth, 5% growth. That one is simply based on the gross domestic product, a measure of economic prosperity that represents the average income per person in the country. You get 10 rich men or women and divide by the population, and they also call me a rich man, when I'm not. Economic development is qualitative and encompasses improved standards of living, quality of life, and social well-being, including key factors such as health, education, housing, and reduction in poverty and inequality. In fact, when I talk about economic development, one of the major indicators is the investment in human development. How are primary issues of education, health, housing, access to water, etc. Economic growth can mask gross inequality, social and economic in the country. It's because I don't have time, but under the post-colonial arrangement, under the federal regime, I demonstrate in this paper how gender inequalities, although they talk about gender disparities reducing, have increased, but that can be masked by the economic growth figures. Other choices range from political, economic, and social freedom to opportunities for being creative and productive and enjoying self-respect and guaranteed human rights. Suffice to point out here that development is a human right. The African Charter on Human and People's Rights recognizes this right. And in 1986, the world got a jewel of a document called the Declaration on the Right to Development, which recognized that development is a comprehensive economic, social, cultural, and political process which aims at the constant improvement of the well-being of the entire population and of all individuals on the basis of their active, free, and meaningful participation in the design, implementation, monitoring, and evaluation of development policies and interventions. The declaration is covered at this page and what emphasizes, but I will not go through that. Building on that declaration, later in 1992, the Rio Declaration on the environment, which also built on the Stockholm Declaration on the human environment, emphasized the need to have people participate in development programs that affect them. And recently, we saw the 2030, how many years are we being missed? To reach 2030, 5 years. And I remember in 2000, when they had said we'll be having healthcare for all, according to the Mother Declaration, and the years passed. And I can tell you, 2030 will pass. But there are achievements that have been made. All of us are conversant with these goals, and they are health-related goals that I will encourage you to take into account. To conclude this part of teasing out the nexus between health, human rights, and development, I would like to answer the question: wherein does the health, human rights, and development, how do they interact? In my view, these broad and complex concepts feed into each other. They are intrinsically linked, interrelated, interdependent, and mutually reinforcing. They are essential for human well-being and survival. Health is critical for the realization of human rights. If you are sick or have an ailment, whether physical or mental, you may not easily exercise other rights, including the right to vote. When they begin beating people and running after others, distributing money in Ogogo, you can't have the energy to run. You can't assemble, you can't associate, and you cannot work. You cannot also meaningfully participate and contribute to the development of your family, community, and nation. As the Committee on Social and Economic Rights observed, the right to health is not dispensable for the exercise of other rights. But the enjoyment of the right to health and other human rights are not absolute. They may be limited provided the criteria at the international level and in our Constitution, Article 43, are met and include the restriction or limitation must be provided by law. It should serve a legitimate purpose, for example, protecting public health and national security, etc. A lack of development adversely impacts public health and may therefore have deleterious ramifications for the right health and related rights. As seen in developed countries, economic development may result in the eradication of absolute poverty and the associated underlying determinants of health, leading to the rise in health incomes. A scholar called Russell Meyer in 2008 observed the social, cultural, political, and material changes that accompany the development process are the causal agents responsible for the steady reduction in avoidable forms of morbidity and mortality. However, market and growth-oriented neoliberal development may have deleterious impacts on the right health and its underlying determinants. I don't have time, but other than NRM, I illustrate how structural adjustment programs, a critical feature in liberal policies, has undermined access to health care and other determinants of health. In my view, what is required is a people-centered and driven development which permits the population to freely, actively, and generally participate in the design, implementation, monitoring, and evaluation of development policy, and demand accountability from the state and non-state actors for denial or violation of human rights, including the right to health. Any meaningful development, in my view, should adopt a human rights-based approach, in spite of its shortcomings, which I highlight here, but I don't have the time. In spite of its shortcomings, which requires that international human rights standards should be placed at the core of all development processes. The human rights-based approach requires observation of the following cardinal principles: participation, accountability, equality and non-discrimination, empowerment, and equality. In applying this approach, planners, designers, and implementers of development processes must move beyond the narrow focus on individual human rights, such as access to health care, and encompass collective health promotion and prevention programs. Health, including health care, goes beyond biomedical factors and embraces social conditions in which individuals and populations live and operate. We must interrogate critical variables such as class, sex, gender, location, and others for us to get a holistic picture of the social determinants of health and outcome tackle. Health comprises more than health-related goods and services and extends, in my view, to critical questions, including non-discrimination, democracy, and accountability. The government of the day, including Uganda, has a social contract with citizens. Honorable Minister Muhanga, the government has a social contract with you and I, and is accountable if it does not meet its obligations, including tackling health care and underlying standards of health. As one scholar observed, health is reproduced, experienced, and understood in the social, political, historical, and economic context in which we live. And there is more than that quotation, but I don't have time. In order to appreciate the concepts of health, human rights, and development further, in my view, it may be necessary to examine, using a historical perspective, how they have been applied through various epochs in Uganda. I'm a lawyer, but I'm an experienced scholar who believes in the role of history in explaining for us the past, as we look at the present, and try to predict the future. I have about 3 pages on the pre-colonial period. I took time to dig out anthropological works and other texts to illustrate the following points. One, that pre-colonial Africa, before the colonial scale, was not a dark continent. There were fundamental developments that took place, given that health was largely a community or collective affair, where kings, chiefs, priests, elders oversaw the promotion of the well-being of the society. But as I note, the pre-colonial period cannot be overgeneralized, since one society varied from the next. So whereas some literature tend to think that women, for example, enjoyed equal rights with men, there is literature which I agree with that there existed gender inequalities, but being masked by the society at that time, but I don't have time to go into that. Traditional medicine was the only health system that existed during the colonial period. We had traditional healers, including herbalists, birth attendants, bone setters, therapists, rainmakers, spirit mediums, faith healers, diviners, etc., who addressed mental health challenges in their community. Health issues were handled in a holistic fashion. Let no one tell you that when the WHO observed in 1946 in their definition that our societies did not have this, in pre-colonial Africa, people knew that health was a serious issue that was to be tackled in a holistic fashion, cutting across the physical, mental, spiritual, and cultural well-being. There was strong family and community support, including education in matters of health. Health moved beyond health care and encompassed the underlying determinants of health during this pre-colonial period, including food, housing, environment, and water. I don't want to fall into that trap of thinking that WHO is the one that invented this definition. We had it in Africa. The African philosophy of Ubuntu, or Ubuntu, Umuntu, Ngabantu, as used in South African countries, loosely translated as I am because we are, or a person is a person through other persons, shaped health practices through a communal approach, which stress solidarity, interdependence, and shared responsibility. Caring for the sick was a collective task, for example, etc. Food was accessible and inflated, families cooked and ate together. There were no beggars, as I see on the streets of Kampala, caused by the vagaries of globalization. There were no beggars and starving people. As such, this food was implemented. In the context of sexual and reproductive health, an area I have spent years promoting, pre-colonial societies had their own SRH practices. The societies took SRH issues seriously. Fertility was highly prized, especially in societies where economic production largely depended on human labor power. Children were critical for, among others, sexually blinded, providing social security, and playing spiritual roles. Infertility was stigmatized, but was managed through various reproductive practices. To ensure infant health, postpartum women practice sexual abstinence through prolonged breastfeeding. Premarital sex and pregnancy were frowned upon and then punished. In Ikigezu, where I come from, for example, if a girl became pregnant outside marriage, she would be thrown on a cliff of cheese balls or abandoned on a lonely island in Lake Uganda, where she would be picked by a man who lacked bridal gifts to marry. This obnoxious practice of throwing the pregnant girls in the falls was abandoned when one girl who exercised her agency sharply pulled the brother along and both died, which shows you that these customary practices are not stated, and the woman, through her agency, ended that custom. Though relations between women and men varied and were culturally specific, in most pre-colonial societies, some women held positions of prominence and dignity and played crucial roles in politics, religion, and economic and other spheres of life. I don't have time. There are scholars like Saidi, Tamale, Roussel, and others. Was there a concept of human rights during this period? The answer is yes. Pre-colonial societies had their own understanding of human rights. I have a lot of writing there, but I'll just say one more line. Pre-colonial societies had their own understanding of human rights, though not in the form of the Bill of Rights as is known today. The Ubuntu philosophy I referred to above promoted human rights that were understood and exercised through diverse community-based systems of customary laws, norms, and practices, emphasizing collective responsibility and reconciliation. Societies gave greater regard to collectivism. Individual human rights rotated around the community, and communalism formed the basis of human rights. Individuals had rights and duties in the community, including their families. So I talk a lot about here, including authors like Murumba and others, and how societies handle this matter. One may also ask, was there development in pre-colonial Africa, or it was simply a dark continent? I know some anthropologists have written wrongly and given a bad picture about pre-colonial Africa. But as an Afrocentrist who looks at some of the negative values promoted by Eurocentrism, I found out through my research that people in pre-colonial Africa, including Uganda, were engaged in various activities such as hunting, gathering, mining, and simple manufacturing, and some form of commercial agriculture. Some kingdoms such as Mali had advanced iron working, sophisticated agricultural techniques, and unique architectural and craft industry. In fact, speaking for myself, my grandfather, who hailed from a family of blacksmiths, told me that before colonialism, they were actively engaged in carving various types of equipment, including spears, swords, knives, and hammers from iron ore, a trade that the family practiced even after independence. There were also very advanced health systems. For example, Professor Sekari Musisi, in 2022, observed that prior to the colonization of Africa, medical knowledge and practices in some African regions surpassed those in Europe. He notes, for example, that Dr. Perkin found that there was advanced obstetric surgery in the Uganda, where a woman who was in labor and the labor had become obstructed was operated upon using a red hot knife that had been brought out of the fire. The letter was cut, the paper was removed, using the half a calabash. The blood was removed, and the letter was touched, and stitched. 11 days later, both a woman and man and child were okay. What am I emphasizing? There were significant performers in the colonial era which were arrested or retarded by colonial entries. In the colonial period, it's a lot. I will just tell 2 things. It's about 4 pages. Colonialism had 3 major aims. 1, search for raw materials. 2, search for cheap labor. And 3, the search for markets for their commodities, where in Western Europe, the market had declined. And they did some development, hospitals, roads, infrastructure, but all these were for purposes of maintaining their hegemony in Africa. But when I talk about colonialism, I wouldn't like us to blame all our ills on colonialism. I do believe that the challenge of the development in Uganda and Africa at large can be attributed both to external, including colonialism, things like the third debt, things like lack of access to markets, but our own internal challenges as a illustrate are also very critical, because we have many years since we got independence. How do we attribute the challenges we have colonial systems? In the post-colonial period, I look at the earlier government of 6 states, and one important matter I underscore is that those governments took health and healthcare seriously, including questions of food and nutrition through things like food storage, etc., up their meal regime, etc. The post-colonial period, 1986-2025, and I was up here commenting on such a regime which has been in power for 40 years, is a daunting task, but I will simply try, but the write-up is here, but a few things. The NRM government introduced structured adjustment programs after trying water trade for a year, and in accordance with its promise in the 10-point program, promoting an integrated, self-sustaining national economy, promotion of democracy and the rule of law, all these are discussed here. The structured adjustment programs expected to improve the state of the provision of socio-economic services, a regulation, reduction in labor force, but I'll talk about privatization of socio-economic services, which commodified healthcare and subjected to the cost of supply and demand, and has put healthcare out of the reach of the majority of the people in terms of affordability. Then I also talk about the questions of inequality created by those neoliberal arrangements, and it's a lot that I researched, but I was constrained by time. Oxfam has pointed out the inequalities in this area. There is also persistent gender inequality in education, labor force participation, and political representation. The demographic and health data show a mixed picture. Uganda is improving in terms of statistics. Maternal mortality has gone down. We don't have the figures of morbidities. Teenage pregnancy is still a serious challenge, 24 to 25%. There are so many. Although Uganda has signed the Maputo Protocol, which allows access to abortion care for purposes of tackling unsafe abortion, Uganda is still taking that step. And so there are many things I talk about. But as I said, I'm not happy that the keynote was not given 1 hour, but I don't care. The keynote, wherever I present it, whether it's in Uganda or abroad, is 1 hour. Because it forms the basis for the discussion of the subsequent days. That's what I want to do. Saturday days, New Year, we're just moving up and down. Really, that's the challenge. The time will keep up, please. The time has reached, but I'll take 10 more minutes. So, conclusion. How do we address the underlying determinants of health? I've already said these concepts of health, human rights, and development are multifaceted, interlinked, and mutually reinforcing, and all of them are affected either adversely or positively by the underlying determinants of health. The WHO recently gave us a very important document on addressing the social determinants of health equity, and it talks about addressing economic inequality and investing in social infrastructure and universal public services, overcoming structural discrimination, managing the challenges and opportunities posed by the mega trends of climate change and digital transformation, and putting in place governance arrangements that will maximize the coherence and impact of action. Building on this, I'll try to break down a few strategies. Health and nutrition strategy. Government should, in a multi-sector manner, tackle gross inequalities in the promotion of health and provision of health care, especially by paying attention to those who may not be able to cater for their health needs. Provision of free health care is critical for areas such as access to emergency care, including obstetric care. This may require reinvigorating the discussion on universal health insurance. Honorable Minister, the discussion on universal health insurance, which I know will be active in pursuit. There is an urgent need to fast-track the universal health insurance legislation and policy. There is also a need to fast-track the regulations determining reasonable charges for drugs, medicine, and other services provided by private practitioners. Honorable Minister, again, Sehat is happy that after going to court and getting a judgment directing the ministry to put to develop regulations for putting forward these reasonable charges, the minister informed us some time back that in advanced stage. We are very grateful for that. Government should provide incentives to private actors that invest in healthcare in rural settings and hard-to-reach areas. There is also a need to expand social security programs beyond the so-called humanizing senior citizens grant, and I use the word humanizing intentionally. Government should ensure community participation of all people in the planning and implementation of health policies, programs, and interventions. Participation should be free, genuine, and informed consent, blah, blah, blah. I won't read them. Government should encourage and promote self-reliance by the people through local initiatives such as making bridge for health centers, ensuring cleanliness and hygiene in their homes. Local governments can pass by laws to enforce this. And I hasten to state that the government should even reconsider the reintroduction of graduated tax, which would make men in rural areas responsible rather than moving in 2 bars every day. Government should provide promotive, preventive, curative, and rehabilitative services, and in this I have in mind, for example, the full implementation of the Mental Health Act 2018 by moving beyond institutionalization of mental health care into community health, where mental health is viewed holistically according to the WHO. Government should provide education concerning preventing health challenges in communities and the methods of preventing and controlling them. The catchphrase, as Agnes told us, should be prevention is better than cure, not like an ambulance moving the accident scene when the accidents are very happening. Government should promote other things. Government should promote food supply and food nutrition. It should encourage people to go and store adequate food. It should support agriculture through provision of extension workers, fertilizers, irrigation schemes, tractors, food sufficiency should be emphasized. Production of the market and exports should be secondary, in my view. People should first have enough food before you think about the market and export. If government provides education, as I'm going to illustrate, free up to university level, people can consume their produce and become healthy. Food sovereignty should be promoted. I don't have time to explain that concept. We need to have stabilization fund and buffer stocks like we saw when we were growing up in the 60s, 70s, and the Obote II government, where government would buy food from areas of plenty, store it, and distribute it in terms of shortage. Government should ensure adequate supply of safe water and basic sanitation. And I can hear the discussion saying you are emphasizing government and not the private sector. I know I'm a believer of government intervention. Water is critical for home consumption and agricultural use. In addition to provision of gravity, water, and boreholes, people should be encouraged to harvest rainwater and store it, especially in water-stressed areas. Government should also devise climate change adaptation measures in accordance with relevant instruments, for example, the National Climate Change Policy and the National Climate Change Act. We should also thank government for the rural electrification programs, but accelerate it and implement renewable energy policies, including provision of solar equipment. Government should urgently tackle sexual and reproductive health challenges, including teen pregnancies and child marriage and unsafe abortion. Government should provide age-appropriate, comprehensive sexuality education. I repeat, government should provide age-appropriate comprehensive sexuality education in those schools beyond the so-called God-centered abstinence-only approach and encompass critical services such as contraceptives and use of condoms. Elite can be brought from Uganda, whose recently passed health rights legislation has lowered the age of contraception access and use 10 years, about 3 years, 3 weeks ago. There is no need to decolonize the criminalization of abortion to allow termination of pregnancy on the grounds I covered that colonization legislation in the other parts. There is also need to decolonize the criminalization of abortion to allow termination of pregnancy on the grounds recognized in the Maputo Protocol, which Uganda signed, especially preservation of human life and health, instances of sexual violence such as rape, defilement, incest, and sexual assault. Governments should follow other countries that have liberalized the criminal abortion regime, such as South Africa, Kenya, Rwanda, Ethiopia, Mozambique, and Benin. Governments should resurrect, that's the means of health, should resurrect the national guideline on reduction of maternal mortality and morbidity due to unsafe abortion, which was signed by Patricia Sheriff. It touches me. The bad midnight council produced this guideline. They were signed by Sheriff. Government should revisit the Homosexuality Act, which promotes discrimination against sexual minorities, thereby undermining their human rights. There is also a need to revisit the criminal provision in the HIV Prevention and Control Act, which enhances stigma and discrimination against persons living with HIV. Education strategies, I will just read just a few. The importance of education, I've talked about it. Government should ensure equitable access to quality education by addressing systemic barriers, including inadequate funding, a lack of educational materials, and poor remuneration of teachers. The policies that favor science teachers over their counterparts of arts and humanities is not only unfair, discriminatory, and counterproductive. It should be scrapped. In the spirit of Ubuntu, parents and the community should be encouraged to contribute to the welfare of teachers and their children while at school. Government should heavily subsidize university, tertiary, and vocational education. This is because most of parents or guardians may not afford education expenses at these levels of learning. Parents sell products in the garden, crops in gardens to raise school fees. The educational curriculum, including that of health professionals, should incorporate indigenous traditional knowledge and local wisdom. The training on traditional medicine should include relevant provisions of the traditional and complementary medicine Act 2019. Economic strategies are just keep a few things. Government should take the right to the women seriously. Government should incorporate this right in its also policy design and implementation by ensuring that the women policy program and practices will not interfere with the enjoyment of human rights. Government should ensure that human beings, individually or collectively, are at the center of all economic activity. That they must be subjects and not objects of the woman. Government must ensure that individuals and opportunity participate as I explained. Those who are unable to do so by all means should be assisted on the means of production, such as land, finance, capital, labor, and technology. The government partners, in quotation marks, or donors, those euphemisms are wrong, because there is no partnership. It is we are weak countries and they are strong. Should ensure that their aid for international assistance respects human rights, economic, political, social, and culture. But national companies and other foreign investors, for example, those engaged in oil exploration and production should observe the human rights of local people, including labor rights, property rights, and environmental rights. The government should cooperate with other states, regionally, and African level. Government should aggressively promote local investment and production. It should accelerate its import substitution strategy by promoting local industries and fostering economic self-sufficiency. This may be achieved through enhanced incentives, subsidies, tariffs, and quotas to protect local investors from international competition and stimulate production and free selling. Trump is not about to make America great again. Let's make Uganda great again by reclaiming our country so that when the type of trade needs to be checked, Tanzania has done it. Some businesses should be exclusively reserved to Ugandans through legislation progressive tax they wish to increase revenue, which can be used to provide social economic service to the poor. There is a need, however, to expand the tax base beyond those who have been compliant to the informal and other sectors that have not been previously taxed. I'm happy to report that the Uganda Revenue Authority and Ministry of Finance are trying to do this. Government should increase funding for health at least 3% of the national budget, as agreed at Abuja. Education funding should be about 20% of the national budget, as agreed at Dhaka. Agriculture should be allocated 10% of the national budget, as agreed in Abuja. Government should invest in the digitalization of crucial socio-economic sectors, such as education and health. There is a need, however, to tackle this new form of colonialism through digitalization by bridging the rule of urban and digital divide and developing robust and affordable internet infrastructure in rural settings in order to ensure internet connectivity, providing digital literacy training and access to computer and or smartphone devices for the people. Computer labs should be established in all public schools and encourage private providers to have those laboratories. Ensure there are sufficient information and communication technology to assist the learners with the digital literacy training. ICT technologies can be used to improve health care delivery and empower individuals and communities to assess their own care through tools such as telehealth, mobile health, apps, wearable devices. We are now even in the robots. To this end, AI and robots. To this end, government should implement the Uganda Health Information and Digital Health Strategic Plan 2020-2024. Firstly, good governance strategy. And I know this will make some people uncomfortable. But if a professor cannot say this,
Professor, try to summarize.
I'm going to summarize. If a professor cannot say this, who should say it? According to the United Nations Economic and Social Commission for Asia and the Pacific, government means I call the process of decision making and the process by which decisions are implemented or not implemented. The views under this good governance strategy are mine as Professor Ben Innovation, and not the organization of which I am chair board of trustees. Separate the two. These are mine. Government may be good or bad. Good governance is participatory, consensus-oriented, accountable, transparent, responsive, effective, equitable, and inclusive, and follows the rule of law. It assures that corruption is minimized, the views of minorities are taken into account, and the voices of the most vulnerable in society are heard in decision-making. To this list, I hasten to add observation of human rights. As to whether it is a good governance in Uganda, I leave it to you. Having made this cowardly observation, I add that the government of Uganda, like most African countries, is capable of significantly tackling all the underlying determinants of it. In my view, it is not merely a mere lack of resources, financial, managerial, and technical, but it is a question of a lack of political will to do so. It is a lack of prioritization in the allocation of resources. The government should urgently do the following. Use the available framework aggressively deal with grand corruption in the country without fear of level. Reduce the bloated administration. Number of members of parliament should be reduced to 1 MP per district. Have a maximum 21 cabinet ministers. Abolish the office of the resident district commissioner and the deputies, or reduce them to regional level. Remove the office of the presidential advisor and assistant. Fast technique and fund existing public infrastructure before establishing others. Substantially reduce the state house budget. Vote of all vehicles for public servants. The exports and guarantee the long-term loans for vehicles. Limit travel for public servants. Control workshops and seminars. And examples are legion. All financial resources saved should be invested in critical areas of human development, such as health, education, and agriculture. The government should ensure democracy and observance of human rights in the country. A country that observes human rights, rule of law, may attract investment, foreign and local, which will increase government revenue through taxation. A country that tortures, abducts, and disappears its citizens, brings elections, will scare away investors, bring economic and political stability. These are which are crucial and aligned determinants of health. Government cannot, I know I had an argument with some people that I don't say this, but I pray to God last night that I should say. Government including civil society organizations. Government should therefore ensure a conducive environment within which these private actors can function. Repressing civil society organization is counterproductive. Thank you very much for listening.
Thank you very much, Prof, for tickling us. And for those of us that had slept, at least there's something that woke us up. And for many of us, we are thinking, how is that related to the right to health? Why is he talking about that? Now, I'm going to take us deeper into this discussion by inviting Dr. Joseph Opare, who is going to help us with the connections in terms of when you talk about the right to health, human rights and development, many times we think the responsibility is the Ministry of Health. So Dr. Opare Joseph, we need to get an indication. What role must other sectors play? Do they even have a role to play? Or this is purely the role of the health sector? Over to you.
Thank you very much, Chair. And thank you very much, Professor. It was such a wonderful, well-thought paper. Chair, let me ask the same question to the audience. Are there actions other MDAs of government can play to contribute to the country's national health goals? Yes or no? Yes. I think the ayes have it. True. We need to leverage efforts from other sectors to be able to achieve our goals in the sector better. And the Honorable Minister this morning, there was a statistic that was shared here, which puzzled me, and I believe many people were puzzled. WHO put up a commission in 2008, and they are here. The Commission on the Social Determinants of Health. Their job was to interrogate how much addressing social determinants of health contributes to the health outcomes, vis-a-vis how much the core health sector contributes. So if you put that in a linear formula, where X is the output of the health sector, busy as it is, with Uganda running across the country, running up and down with Remuka, with ambulances running up and down, with the hospitals busy day and night, all that in the sector will contribute only 20%. That was the statistic. The core health sector. The other 80% contribution to the current health outcomes that we have is coming from addressing underlying determinants of health, which Professor has explained. 80-20. So for us who are managing the health sector, we're contributing only 20%. So that demonstrates that we need to move close to the other actors who are handling the determinants of health. The professor has told us there are social health determinants like education, housing, employment, and many others. There are economic determinants, poverty, access to resources, income, and then there are environmental determinants, access to clean water, sanitation, and environment, classified as such. Now this 2080 statistic was out of that commission which produced the report in 2008. Maybe the picture today is different. I don't know. But maybe not very different. So WHO, since they are here, I think that's almost a decade, more than a decade ago. Maybe we could get another look at this statistic. 28 is really bad. So, no wonder the audience has said yes. We need other players to come in and make a contribution. And I will not go through all the sectors, but just as an example, when you look at the infrastructure development, when you look at Minister of Works, what contribution could they do? For example, ensuring that our roads and infrastructure are in place and are well maintained to facilitate access to our facilities. That alone will make a huge contribution. When you go to our hospitals, accident and emergency departments, they are full with border accident cases. Could we do something to reduce on this? And they're taking a huge chunk of our budget. That issue, I don't think the health sector can do much. It's another sector that can help us better than we can do ourselves. But of course, working with them. Minister of Education, if you just pick the issue of teenage pregnancy alone, because of the dropouts from school and lack of education, many of our girls are ending up wasted because they get pregnant. Teenage pregnancy is 24 or 25%, which is still very high. There's a lot that Minister of Education should be able to do. Minister of Water and Environment, colleague senior officer from Ministry of Water has been demonstrated here what they can contribute as water. Regulating and ensure that safe water and sanitation is available and waste is managed properly so that disease outbreaks do not disturb us. Minister of Finance, Planning and Economic Development, they are the ones who provide the plan that all these sectors we're talking about will require to make a contribution. So they have a big role to play. Sometimes they don't appreciate the role they have. Sometimes they just believe that to have better outcomes, let's just give Minister of Health money and it will come out. They also need to appreciate that other than Minister of Health, all these other ministries or sectors have a role to play. Minister of Gender, a lot. They need to empower the community, mobilize and empower the community to be able to manage themselves and also to seek care. This is the aspect of occupational safety and health, which is also a Ministry of Gender. And above all, we have the cabinet and we have parliament. We have a health committee in parliament and we have cabinet. These are all sections of government that need to come in and to address this issue of underlying determinants of that. Ladies and gentlemen, in Uganda we have moved a step on this because, as you know, we are now on program basis away from the sector. So we have a human capital program which has health, education, gender, and water working together. But this has not moved from paper to reality. We need to actually work together, plan together, and implement these things together if we are to see better outcomes. So yes, every sector has a role to play on that chair. Thank you.
Thank you very much.
Dr. Opare for actually allowing us to now get into where National Planning Authority is. Actually, where you ended is telling us, A, it is all our responsibility, and then number two, we have the way in which we organize how we are doing our national planning. So now we invite Dr. Munira from MPA to kind of give us an indication. What can be done? How do we get that attention? Dr. Opare has said actually it is on paper. We even have a brand NDP4, which is even all the way up to where we're ending in the SDGs. What can be done? What more do we need to do? How do we take our responsibility than moving blame to another person? Over to you, Dr. Opare.
Thank you very much, moderator, and thank you, Dr. Opare and Professor, for that insightful keynote. My name, I'll say again, is Munira Babazin. I am sitting in here today for my Executive Director, Dr. Joseph Mvawala, for whom I bring greetings to you. So the question is quite interesting, and the ground has been laid for us to understand the roles of the National Planning Authority in ensuring that at the end of it all, we realize better health outcomes for Uganda, for the Ugandan population. So central to the National Planning Authority is embedding health within its development agenda. Like Dr. Opare clearly puts it out within the NDP4, which was launched early January. What we see is that within the NDP4, we speak to quite a number of programs, but above which is the Human Capital Development Program, for which health is anchored. And when we look at the Human Development Program, it is not the only program that entirely contributes to the health ecosystem. We have other important issues that we look at in the other AU programs. So what we are saying here is that at the end of it all, we are supposed to be working on bringing together the different sectors, different agencies, among very many others, to work towards providing plans that speak to this broad agenda. One of the defining contributions for NPA has been the shift towards program-based planning, which emphasizes that the interlinkages across sectors. This is not only a health program, a health sector program, but a general problem that we need to address. So within the Human Capital Development Program still, we are saying that we need to bring also other issues around agro-industrialization, governance and security, community and mindset change, among very many others. One of the skills that were played for us here today clearly put out that our social determinants of health go beyond the health system, and we can't leave this only one group of actors to act on. And what we see further is that within the NDP4, government or NDP, the NDP or NPA, we are emphasizing that at the end of it all, for us to realize these gains, as we work as programs, in as much as the realization of the program working is still low, but the efforts to ensure that that actually happens. Can we work towards getting data through monitoring and evaluation that ensures that at the end of it all, we are able to track progress? It is hard for us to speak about progress without the numbers. So the strategic plan emphasizes that we work with performance monitoring, evidence-based policy, and spatial planning to promote equitable service delivery. And the issue of health is about equity, and service delivery is central. We understand the challenges that health systems face especially around equity, where we still have very high patient number ratios. The health workforce has not many health institutions will tell you that they have not reached even 30% of what they're supposed to recruit. So those are quite a number of issues that we need to do. So in doing that, what we need to do, or what NPA is doing, NPA is quite instrumental in ensuring that at the end of it all, national health priorities speak to the international and regional commitments in health, like we see for the SDGs, but we also realize that health is a cross-cutting issue, and it has both enablers through domestic, enablers that can give us, we have to work at issues that give us domestic transformation, and at the end of it all, global competitiveness. What therefore can we do differently? What we can do differently is we need policy coherence. As we are working through the programs, we cannot have different policies speaking different or highlighting different issues, but do not speak to a common framework. So it is important that we do that. We need integrated data systems. Data has to be in place for one to help us plan, and at the end of it all, enable us to plan within the contexts that exist. And then also we need participatory planning. We cannot sit at the National Planning Authority and pretend to know everything that is happening within the country. But our goal is that can we participate in the planning? Can we see to it at the end of it all that all our voices are reflected within the plans that we come up with and work towards that? And then, yes, there is an issue on financing. We need to speak sustainable financing. There should be models that give us sustainable financing, especially in the light of the decreasing donor financing spaces. We need to speak to that. But as a country, how do we finance our health systems? How do we speak to, how do we ensure that at the end of it all, health financing is clear and sustainable? Yes, issues have been raised about the health insurance. That is a good approach to take, but there are quite a number of prerequisites that we need to put down, to lay down, so that our health insurance schemes work better. One of them is basically around infrastructure, and another is about the health workforce. So we need to plan at the end of it all to see to it that we deliver the actions that we ask for. And then another is going to be accountability mechanisms. One of the challenges that actually is failing many of our systems is the lack of accountability. In as much as our health workforce is lean, but quite often we actually not at the health facilities with the patients to show up. So how do we institute an accountability mechanism amongst ourselves? So it is important at the end of it all that we work towards that. So those are some of the few actions that we can take to ensure that at the end of it all, we realize what it is that we seek to take. So also as I conclude, yes, we are aware of our youthful population, and it's ambitious development goals that we set. And we also note that health is a human right, and the time to act is now, but we are not going to act independently. We need to act together, and yeah, that is it basically. But also I would like to further note that this conference, second in nature, should be more of a conference of stock-taking, especially on commitments that we make. So I would love to see to it at the end of the day that for the previous commitments that we made at the first conference, we are able to see how much we have moved before we even commit to the next set of commitments. Thank you very much.
Thank you very much, Dr. Munira, for having allowed us to understand where we are located as a country, but also the roles that we all have to play in terms of ensuring that we are weaving the connections and also giving life to MVP4. Now, the last panelist that is going to enable us to really continue weaving and breaking down the keynote is somebody who comes in from a gender lens. When Professor was discussing, he was talking about how equality and equity are critical, but also research has shown that we can't proceed and have equality and equity of sustainable development without addressing the gender differences. And this is gender beyond male-female binaries, but gender in its broad understanding. So I'd like to invite somebody from the School of Gender and Women's Studies from Makerere University to help us understand what is it, what do we hear from Professor's keynote, but also what is it that you would recommend us to think through as we're looking at the next 2 days. Over to you, Donna.
Thank you so much, moderator, for this afternoon. My name is Donna Kevinji, and I'm sitting in for the very able director of the Institute of Gender and Development at Makerere University. And my job looks rather wider than I thought to sum up what the keynote speaker explained deeply to us and also what the panel has discussed. One, when we reflect on what Professor Trinoucha spoke about on, first of all, development, it comes from a point of a lawyer perspective. And so to bring the advantage of gender, but I first of all, I am a political scientist, but I get major in gender. So as a political scientist, that's what we can call a see. So when we look at human rights being inherent, and the government actually taking the obligation to deliver the rights, and so Professor, first of all, reflected on the colonial time and says during the colonial era, there was health. But what kind of health was that people were getting? How equally distributed was it? The health centers, that when we were to look back at the health facilities that were born those days, were in places of intense production. So literally, if you look at Jinja, Kampala, there was enough access to health at the time. But if you have an animal that is bringing you money, it is on you to make sure that it is actually looked after. So when we look at other places that did not have this kind of production intensity, the access to health was dire and different. And so now, in this era, where the government, we thank it so much, has gone ahead to improve access to the health centers. There's been health centers 2, 3, and 4. And some of these health centers have actually been upgraded from 3 to 4. But then, how financed are they? And how equitable is the health that the public accesses? Recently, I was in the research field in Bani, and almost the entire population tells you, yes, we're able to access the health center for. But for every time you access it, your prescription is given to you on paper, and you're expected to go look for the medication for yourself, which means that you have to pay for this medication. And so, like my fellow panelists, Dr. Munira has talked about the planning. How are these populations being planned for, that at least someone is able to not just go to access healthcare, but rather live with medication? So if we are simply having access, you just have a right to access the healthcare, but actually the actual sense is that you have a right to access the health facility, but not the care because you cannot afford it. We've had a common saying now that every Ugandan nation is one health bill away from poverty. If all of us in town in Kampala, I believe we're all here in Kampala, all of us are just a bill away from one day in ICU to back to poverty. So what does that call for Sarah that is in the village and cannot even access antenatal and later on a Panadol? So these are these are the bottlenecks that such a conference is supposed to speak to and address. The other thing I can talk about is on development. The very able professor still referred to Professor Amartya Sen of the scholar on economics from India. First of all, Amartya argues that development is a freedom. But then what is a freedom that does not give you opportunity and access? So, if we are going to call this a freedom, a human right, and that should be inherent for everyone just because you are a human, how accessible and also how accessible is it for not just all, because when you say all, when everyone says people should access, most of the time when you say people is men, or people is the able. So how are we looking into the woman that is in, I'm still referred to Sarah that is in a village and cannot access this, but also Sarah's husband, who is in the village and maybe has actually accessed education but has no job, because we know the employment situation of the country. Sarah's husband that is in the village, that who even can access a job that is exploited and paid 30,000 shillings after a whole day's work. So these are the kind of aggregations that we're supposed to look into as the planning department, as the people, as the MTAs that are in charge of these small pieces that come together to bring up the budgeting. And so I thank the Ministry of Health for such kinds of spaces, because this shows that they are not shying away from the accountability, even availing accountability spaces to the public. And so in conclusion, I'll go back to, if we did not speak much, go back to what Professor's recommendations were. He deeply recommended, and his words were very gender specific, to inclusion. He talked about an inclusive education, an inclusive healthcare system, not just us to say we need an inclusive education, but rather looking at a girl that was affected by COVID, looking at the smallest aspects of the disabled child. So I'm going to refer this panel to the recommendations that the professor gave in the keynote address. Thank you so much.
Thank you very much. The purpose of our keynote address is not to be discussed here. It's actually to whet our appetite. Can we see by a show of hands whose appetite has been whet for the next 3 days? You're dying to have these deeper discussions. Yes. Because we have an agenda that has so many sessions, but also so many plenary sessions. My role here is just to wrap it up and indicate, there is a keynote. Which keynote is going to be shared with you? There's going to be a QR code that is going to be on the screens for you to look at the keynote and look at the issues. The keynote is further broken down into all the various oral sessions and the plenaries that you're going to have. Let's continue the conversation. What is very clear that all the keynote speaker mentioned is that there is a huge relationship between the right to health and development, but also we can't run out from that nexus. What is very clear is that we all have a role. We can't keep pointing one finger when 4 fingers are pointing to us. Another key reflection is that there is a lot we need to do as a country, as citizens, especially without addressing issues of inequality that might be around gender, might be around age, might be around ability, might be around sexuality, might be around social class,
might be around where we are located in terms of geographical location. In other words, unless we politically, intentionally, and deliberately address inequalities, we're not going to be able to achieve the health outcomes. Of course, lastly, is that we have just started the journey. The journey has just started, we've done a lot, but we need to continue. With that, I'd like you to join me to thank our keynote speaker and the panelists for having whet our appetites that we are ready to engage in very deep discussions for the next 3 days. Thank you very much.
All right.
Let's be upstanding for the Right Honorable Prime Minister.
At this opportune juncture, ladies and gentlemen, we'll keep to our feet and we'll observe the national anthem for Uganda and the East African anthem. I will ask our distinguished guests on the podium to take their seats. I will ask our delegates to also take their seats. Allow me to invite to the podium Dr. Olara.